Medicare credentialing of nurse practitioners and PAs. Can you kind of explain what that means? I know there's a lot of questions out there. Does everybody need to have Medicare credentialing? What's the difference if they do, if they don't? Just explain how that works in urgent care.
In the urgent care setting, all mid-levels, essentially all mid-levels, need to be enrolled in Medicare. The reason is, even in primary care it's important in most cases. The reason is, unless the physician goes in and sees the patient, you cannot bill under the physician's number. Okay. The second thing is, unless you're doing incident 2 on subsequent visits, you can't bill under the physician number. Incident 2 means the physician needs to be on site, and the mid-level needs to be following a treatment plan that was designed by the physician on the first visit when the physician saw the patient. The problem is we're urgent care.
Right.
We're not setting up treatment plans.
Right.
So the answer is your nurse practitioners, your physician assistants, they need to be enrolled in Medicare in order to bill Medicare in almost all cases.
So if they're enrolled in Medicare, then they can primarily see the patient, even on the first visit. They can bill Medicare under their Medicare number, and that solves the problem essentially.
Correct.
Okay.
Exactly.
All right. Good. So then the physician doesn't have to now tell us the difference between, okay, there's that problem, and then problem number 2 is physicians in the building, physicians not in the building. How does that work?
That's very state specific.
Okay.
In most states, a physician needs to be able to be available,
Okay.
which usually phone in most states is adequate.
Okay.
So in most states, that's adequate. In some states, for example, Tennessee, a physician needs to sign every PA's chart. Okay. In other states, for example, I believe it's Washington State, a nurse practitioner doesn't even need a supervising physician. A physician doesn't need to be on site, doesn't need to be supervising. They can put up a shingle and see patients.
Run their own clinic, essentially.
Run their own clinic without a physician.
So you kind of got to know your state-specific laws.
Exactly. Exactly.
Okay.
But as far as Medicare goes, a physician does not need to be on site. It has to do with state licensing laws.
Okay. So as long as you have a physician who's available in most states by phone call, for consultation, etc., and they have a Medicare number, they're usually able to see the patients on their own.
And bill Medicare.
And bill Medicare.
Yes,
I'm sorry. Yeah.
correct.
Okay. Next question that keeps coming up, and it seems very controversial. You and I were talking about it over dinner, and that is this whole idea of who has to document the history of present illness, who has to ask the questions, who actually has to write it in the chart. How specific are they being when you get audited? And can you kind of just go through that and what you know about it and where we're at in that world?
Well, Medicare has made a significant shift in the last few years where Medicare has now said the physician is to obtain the history of present illness. The physician doesn't necessarily need to be the one documenting the history of present illness, but it is not compliant for somebody to go in, document the history of present illness, and the physician to come in afterwards and say, reviewed and agreed. The physician actually needs to actually talk to the patient, and they should really be documenting the history of present illness. Can an ancillary staff person put in the chief complaint? Can they put in location and duration? Well, CMS has never said that they absolutely can't document any aspect, but a strict coder would say you really don't get credit for anything the physician didn't document. So it's been in flux over the last few years, but recently CMS has been pretty clear. Physician or provider needs to document the history of present illness.
Okay, good. So that seems very confusing. I hear a lot of people asking that question, so I think that'll help. And let me ask you this. What are the other kind of hot topic buttons right now that people are talking about in the sort of coding billing world?
Well, that's a tough question off the top of my head. I would say the biggest issue I get questions on all the time, new versus established patients. Can't I say every patient is new in the urgent care setting? And the answer is no. You have to follow the CMS rules. CMS rules are fairly specific. If a patient has not been seen in that clinic in the last 3 years by a physician of the same specialty, or a mid-level supervised by a physician of the same specialty, then they would be a new patient. The problem is in urgent care, you could have an ER doctor and a family doctor working. Could you bill under the ER doctor a new patient and the family doctor, again, a new patient? Yes, following the rules specifically, you could. Many payers, when we've talked to them, say, absolutely, follow those rules, no problem. The truth is, we feel like, in our clinics, we feel like that's playing games with the rules. We think patients wouldn't appreciate that. And so we basically said, if they've been seen in our clinic in the last 3 years, then they're an established patient. you don't really have the option of saying, no, every patient that comes in with a new problem is a new patient, unless you have an agreement with a payer to do it that way. And we do have agreements in our own clinics with payers that say that every time a patient shows with a new problem, we code them as a new patient. But the only way you can do that is if you have an agreement with the payer, and don't even try to do it for Medicare and Medicaid. You can't do it that way.
So if you can get an agreement with the payer saying if they're coming in as a new problem, then we can treat them as a new patient, but that better be a specific agreement between you and the payer.
And there's another caveat that some states have come up with. For example, Illinois, in Medicaid, if the patient has ever been seen by that provider in that clinic, then, or has ever been seen in that clinic by any provider of any specialty, even if it was 10 years ago, they're still established. So be careful with Medicaid, they make up their own rules.
And the general rule is how long to be a new patient again?
3 years.
3 years is the general rule to have that. Okay, good. So as we go through and we're doing one of the questions I had, and the patient actually called me and asked me this question. It wasn't a patient of our clinic, interestingly. It was a friend of mine who was a patient in another clinic, and he said, look, I go into my doctor, and every month I basically go in and I get my medicines filled. So I go in, I get my blood pressure medicine filled and whatever. And he says, in 1 month I get charged as a level 3 established, the next month I get a level 4 established, the next month I get a level 3 established, the next month level 4 established. He said, I'm having the exact same thing happen every single month, and every month I get a different charge. How does, as a coder, as a biller, is there such variation on a person who's coming in for sort of the repeat thing that there could be a variation in that charge based on the way the chart is filled out, or is it just that it just happens?
Well, obviously something's different.
Something's different. I was having a hard time answering the question.
And it may be imperceptible to the patient. It may be that the physician's not really understanding the coding rules. I would say that's fairly ubiquitous.
So one physician thinks that's a level 3 follow-up, and one thinks it's a level 4.
In all the years I've talked to physicians about coding, I found 2 physicians, and probably over 1,000, that I've talked to that really understand the E&M coding rules. They really are arcane, they're difficult. There are 2 issues with E&M coding. Number one is getting the algorithm right. Most physicians can't get that right. The second is medical necessity. Now, I think most physicians can understand what's medically appropriate to document on a patient. What's amazing to me is how many physicians think it's not appropriate or not necessarily to document the skin on a patient with abdominal pain. And you ask them, well, did the patient have shingles as a cause of abdominal pain? No. How do you know? You examine the skin. Back pain, same thing. Chest pain, same thing. So many times physicians take for granted they did an exam item that they don't take the credit for. So if a physician's documenting what they did and they're following the coding algorithm correctly, and another physician is not necessarily documenting everything they did, then you definitely will end up with a different code, even though the second code, the higher code, met medical necessity.
Yeah. And in my background in emergency medicine and through the last 5 years doing urgent care, I don't like my doctors, nurse practitioners, or PAs coding their own charts for those same reasons, because I've had 40 doctors work for me and I haven't found one yet who understood the coding rules. So I'm a firm believer in either having a software that does proper coding for you and or a coder that does a certified code. Well, we use certified coders to do our coding for us for that reason, to sort of take it out of the physician's hand. That's my personal opinion. I know there's a lot of clinics out there that the doctor does their own coding.
Well, I think it's important, whatever you do, that somebody knows how to code, and it's rare that the doctor's going to really know how to do that.
Well, it's hard to keep up on everything.
The important thing is document everything, do everything that's necessary, everything that's medically appropriate, and then document everything you did, and then somehow, either with a coder or an algorithm, get the proper code through what CMS's algorithm. Almost always, doctors cheat themselves out of money because they underestimate what they actually get.
Right, I completely agree with that. Good. So, any other hot subjects? Anything else you want to talk about?
Nope, it's been great fun. Thanks for having me.
We're happy to have Dr. Stern down here. We don't often let Yankees down on the ranch in Texas, but we made an exception for him. So we will talk to y'all next month, and take care, everybody. Thank you, sir.
Thank you.